Hello, greeting from Dr. Tindente. I am Senior Lecturer from Faculty of Medicine and Health Sciences, University Malaysia Sabah. Our group developed MOOC regarding male genitourinary tract. Now, I focus on the BPH, benign prostatic hyperplasia, concerned with the etiology, pathogenesis, morphology, and clinical features. Okay, as you all know, prostate gland, it is a retroperitoneal organ encircling the neck of the urinary bladder in the urethra. The weight of the normal adult prostate gland is approximately 20 grams and it is devoid of distant capsule. Testicular androgen control the growth and survival of the prostate cells. Prostate gland is biologically and anatomically divided into 4 zones. These are central zone, transitional zone, periurethral zone, and the peripheral zone. Most of the benign hyperplasia occurred in the transitional zone and carcinoma arise from the peripheral zone. This is the normal histology of the prostate gland. Prostate gland are lined by the two types of cells. One is the outer cuboidal epithelium covered by the tall column epithelium. There are small papillary enfoldings of the epithelium, and the glands are separated by the fibromuscular stroma. And we move on to the benign prostatic hyperplasia, in short term called BPH. BPH, it is the most common benign prostatic disease in men more than 50 years of age. It is a nodular hyperplasia of prostatic stroma and the epithelial cells. It often causes the urinary obstruction. Nodular hyperplasia is not considered to be a pre-malignant lesion. The incidence of the BPH is 20% occurred in 40 years of age, 70% in 60 years of age, 90% in 80 years of age. This is the urinary bladder, this is the normal prostate gland, and this is the urethra. In BPH, it is characterized by formation of large, fairly discrete nodules in the periurethral region of the prostate. When it is sufficiently large, it compresses and narrows the urethral canal, cause the partial or sometimes complete obstruction of the urethra. Regarding the etiology and pathogenesis, the main androgen in the prostate is dihydrotestosterone DHT. DHT, it is an enzyme 5-alpha reductase type 2. It is located entirely in the stromal cells. Prostatic epithelial cells do not express this enzyme. DHT binds to the androgen receptor, which is present in both stromal and the epithelial prostate cell. Binding of the DHT to the androgen receptor stimulate the transcription of the androgen-dependent genes, which include several growth factors, such as fibroblast growth factor and transforming growth factor and their receptors. So DHT induces these growth factors act by increasing the proliferation of the stromal cells and decreasing the death of the epithelial cells. This is the morphology of the BPH. In BPH, the weight of the prostate gland becomes enlarged, approximately 60 to 100 grams. The site is almost exclusively in the inner aspect of the gland transitional zone. In early nodules, they are entirely of the stromal cells, but later it is predominantly epithelial nodules rise. The nodular enlargement may encroach on the lateral wall of the urethra to compress, and it causes the slit-like orifice. The enlarged prostate gland may project up into the floor of the urethra as a hemisphere mass directly beneath the mucosa of the urethra. It is termed the median lobe hypertrophy. On cross-section, the nodules vary in color and the consistency, depend on the cellular content. The glands are yellow and pink color, soft in consistency, and it exudes the milky white prostatic fluid. Nodules primarily composed of fibromuscular stroma. It is grey in color and tough in consistency. Although nodules do not have true capsules, the compression of the surrounding prostatic tissue creates a plane of cleavage above them. So this is the microscopic features of the PPH. There is a glandular proliferation which takes the form of aggregation of small to large cystically dilated glands. These glands are lined by two types of cells. Outer cuboidal cell, it is covered by the top columnar epithelium. The glands are separated by the fibromuscular stroma. Patients with PPH may present with the increased urinary frequency, nocturia, difficulty in starting and stopping the stream of urine, overflow of urine, we call dribbling, also painful maturation. There might be problems or complications regarding with the PPH. The major clinical problem of PPH is urinary obstruction. It is due to increased size of the prostate and the smooth muscle mediated prostatic contraction. So there is increased resistance to the urinary outflow. The urinary bladder becomes hypertrophy and distended, accompanied by the retention of urine. If it is acute retention of urine, emergency catheterization is needed to relieve the acute retention. So the bladder becomes hypertrophy and distended. The bladder is unable to empty the urine completely. So it creates the reservoir of the residual urine and it becomes source of the infection. Thank you very much. In our next video, we will discuss about the management of the PPH. Thank you.